out of the 19 maternity hospitals, there was 11 providing the abortion services. Why aren't all the maternity hospitals providing it?
Let's say someone's 11 weeks and 6 days. They come to see you. They have to wait 3 days and they're over that 12-week rule and they can't have a termination in Ireland, and they then have to either travel to the UK or continue with the pregnancy. I think it's a little bit patronising. I think people have already thought about their decision before they come to that consultation. And certainly listening to politicians, what seems to be being said at the moment is that they don't want to change a huge amount. But I guess if there was one thing that I could pick, it would be that 3-day rule for the under 12 weeks. If we could get rid of that. We do have too many C-sections. I was induced with my first baby.
Were you?
I was.
We're nearly at 50% induction for first-time mums.
For first-time mums.
Okay.
Yeah. So it's very high.
Is it because women are having babies older as well?
That is a factor.
Okay.
Partly because of that stillbirth risk, partly because we know that diabetes in pregnancy and high blood pressure are more common as women get a bit older. Most women who have gestational diabetes, who are diet controlled and have a normal sized baby, can be induced at 7 days over, like someone who doesn't have diabetes, and that both they and their baby are absolutely fine. They don't really want an episiotomy. Like, who does?
But it's better than tearing though, isn't it?
It's better than a 3rd-degree tear, which is where the tear extends down into the anal muscle and can leave you with incontinence.
Welcome to my podcast, The Laura Dowling Experience. Many of you will know me from my Instagram page at Fabulous Pharmacist, where I love to shine a light on topics that people normally shy away from. Today I spoke with Dr. Vicky Dwyer. Vicky is a consultant obstetrician gynaecologist working out of the Rotunda Hospital in Dublin. We discussed the abortion services that are available in Ireland today and their limitations. We discussed Vicky's thoughts on home births and birthing plans. We discussed why the C-section and induction and intervention rates are so high in Ireland. We discussed Vicky's work-life balance and how she makes it all work. And then we also discussed what the new consultant's contract will mean for private maternity care in Ireland in the future. To support the Laura Dowling Experience, please check out my sponsors in the podcast notes below. Enjoy the show. Vicky, it is an absolute pleasure to have you on the podcast. Thanks so much for joining me. I have so many questions that I want to ask. We'll try and get through 3 of them at least, okay?
Grant.
I wanted to start off talking to you about the abortion care services in Ireland today, because I think when Repeal the 8 came in, we all thought, yay, abortion's here for everyone and it's a really transparent service. But I don't think that some women experience it in that way. So can you explain what women can expect if they are seeking abortion and what the limitations are?
So to explain it, we probably have to divide them into 3 groups. So the first group is those that are under 12 weeks, or the pregnancy hasn't exceeded 12 weeks, and we're counting that as 12 plus 0. And for those women, they can choose to terminate and they don't have to give a reason. The difficult thing for that group is that they have a 3-day wait. So they see a doctor, and it can be now a phone consultation since COVID. They then have to wait 3 days and come back to see that doctor to have medication or to have surgery. And that's one of the things that's currently being reviewed in the review of the legislation, which was always planned for 3 years after it was introduced.
Okay.
The second group is the fatal fetal abnormalities. So they're women who have, let's say, maybe an ultrasound scan or a prenatal test, and it comes up that the baby has a life-limiting abnormality. And the law says very clearly that those women can terminate a pregnancy if it hasn't reached viability, so that's 23, 24 weeks, and if it is certain that the baby will die within 28 weeks of birth. So there are a number of conditions that fulfill that, but there are other conditions that are associated with significant health problems, disability, and they aren't allowed for within our legislation, they're allowed for within the UK. So that means that there are some women still travelling for that reason.
Okay.
And then the third group are where there's a risk to maternal health or maternal life. And they probably make up the smallest number of women actually. So let's say someone has a life-threatening infection. So like what happened to Savita Halappanavar.
Okay.
that if the pregnancy hasn't reached viability again, that pregnancy can be terminated to save a woman's life, or if that woman's life would be put at risk by the pregnancy continuing.
Okay. And how many weeks of pregnancy is that up to?
So up to 23, 24 weeks.
Okay. And with the first group of people, that 3-day rule, does that infantilize women? Does it,
Yeah.
what do you think of that?
What I've seen in real life is that the people who are uncertain on day 1 are uncertain on day 3.
Okay.
And I think it's a little bit patronising. I think people have already thought about their decision before they come to that consultation. And it was really interesting, the IFBA published figures on it recently, where they said that 97.5% of people went ahead on day 3 and 2.5% didn't. But we don't know, would those 2.5% gone ahead if they hadn't had to wait? Probably not, because they're unsure for some reason. But where it does make a difference is, let's say someone's 11 weeks and 6 days and they come to see you. If they have to wait 3 days, then they're over that 12-week rule and they can't have a termination in Ireland, and they then have to either travel to the UK or continue with the pregnancy.
And so are we looking to scrap that 3-day rule then?
That was one of the things that came up in the review of the legislation.
Okay.
But I don't know if they're going to change that or not.
And has it happened that women have come at 11 plus 6 and they can't get the abortion, then they have to go to Ireland, they have to go to England?
Yeah, absolutely. Yeah.
Okay.
Yeah.
And can I ask you about the medical abortion, which is someone needs to take a pill? Is there a thought there that it makes it easier for an abortion to... It makes it more simple. It's less of an ordeal for a woman. It's not as if it's invasive. She's not having to go and have her operation and have it done that way.
Yeah.
Does it somehow make it less serious a thing? Is that a thought that comes up?
The earlier you do it, the safer it is.
Okay.
So there's less pain, less bleeding for someone who has an abortion at 6 weeks compared to someone who has it at 11 weeks.
Okay.
And that's why it's in the community under 9 weeks, and over 9 weeks is in hospital, because those risks go up. So bleeding risk, we can give additional painkillers if they're needed. So between 9 and 12, it's all done in the hospital.
Okay. And there's some counties in Ireland that there may only be 1 or 2 service providers. So there is this conscientious objection, which doctors are allowed to say that they're not going to provide the service. But actually, is it a case of they're just not bothered with it? It's a bit of a pain. They don't want really anything to do with it. They don't actually object to it, but it's too much hassle.
Yeah, it's a difficult one. So I think 11 of the 19 maternity units are providing it. And then the GP cover, it varies per region. Like, I have a friend who provides the service in Galway, and she's possibly the only or maybe one of 2 people in Galway, I think, that's providing it.
Yeah.
And I'm not sure why people choose not to. Some of it is conscientious objection, and some of it is that people maybe just don't want to get involved and someone else can provide that service.
Yeah, I've spoken to a GP in a county that they may be the one and only provider in that county, and they've had to see people in their car to give it to them, almost like, or to have the consultation, because it's just... And she says it's terrible for the woman that it's almost still cloak and dagger sometimes.
Yeah. And I think for doctors as well, maybe people worry about what people will think about them. And I know I spoke out about the 3-day wait on Twitter and got absolutely trolled for it.
Did you?
Yeah. Like a huge amount of backlash. But I feel very strongly that, a woman can make a choice and doesn't need a 3-day wait to make that choice. And I think when you are involved in the termination of pregnancy process and you see the women coming through, and they'll often want to tell you their stories, and we never ask, but one of the first women that I met who had a termination had breast cancer, and her survival would have been impacted by continuing with the pregnancy. And like, I really thought about it the first time I was involved. I thought, I'm not sure about this, I'm not sure how I feel about it, but I was like, it's not about me, it's about her. And she went ahead, and I was involved in the process and was fine about it. And it's really, you have to put yourself in their shoes. lots of different reasons people have terminations. And I think certainly in the Rotunda, the patient population we see can be quite disadvantaged. So we have asylum seekers, we have women who are impacted by domestic violence, and it's about keeping them safe and helping them.
Yeah.
And that's why we provide the service, so that it's safe.
And you know that the argument that some people are making to say, oh, you're making it too easy for people. It's just like taking a morning after pill, so they don't even have to think about the fact. It's just like they're taking it and they'll have a heavier period.
Yeah.
So actually, that pill that you're giving them, it just makes it less of a serious thing, and you know people will come time and time again to get it. What are your thoughts on people that say that?
I think if they come back again, it's a flaw in the service. So one of the core parts of the service is contraception. And the government have recently funded free long-acting reversible contraception for women attending termination of pregnancy services in the maternity hospitals, irrespective of age. So there isn't the 25 years of age cap, that any women can have a coil fitted for free. That coil is provided free. So if they come back, is it that we haven't discussed contraception, we haven't given them enough options? And it is rare, I think, for us to see people come back again and again.
Okay. So the fatal fetal abnormalities, that's up till 23 weeks, and then post that, people have to go to the UK, isn't that right? But generally, are those fatal fetal abnormalities picked up by 23 weeks? Is it rare that pregnancies go beyond that?
So most hospitals in Ireland offer an anatomy scan between 20 and 22 weeks, and that's usually where it's picked up. But I guess there are some units that don't offer that, and it may be picked up later at another scan or another visit.
Okay.
Sometimes it can be picked up on prenatal testing as early as 10 weeks.
Is that the Harmony test?
Harmony test, yeah, or Panorama is the other one.
Can you explain what that test is?
So that test is a blood test where we take the woman's blood and pick up the baby's DNA within it, or the fetal DNA within it. And that can give us the chromosomes. So the common ones we would pick up that would be fatal would be Patau syndrome and Edwards syndrome, where there's an extra chromosome, and that condition is fatal. You will see that those babies have abnormalities on ultrasound, but you might not see it till slightly later on, but you'll certainly pick it up on that test, which is 99+% positive. Now, it is a screening test, so we usually would recommend a diagnostic test to confirm it, which is taking a little sample from the placenta or from the fluid and amniocentesis.
Okay. And you did mention that there, out of the 19 maternity hospitals, there was 11 providing the abortion services. Why aren't all the maternity hospitals providing it?
It's a good question. I guess you have to have a provider, and I think you need to have more than one provider. So it can't fall to one person, because what if they're away? You know, what if someone needs a surgical termination, and because their 12-week cutoff falls on a Wednesday, but their list is a Friday, who's going to do that procedure? So I don't know which of the 11 are providing. I know the 3 Dublin maternity hospitals are Cork, Galway, but other than that, I'm not sure.
Okay. So is it a case of there isn't enough either midwives and doctors that are willing to provide the service, and that's why they're not being provided? Yeah,
because every unit would have received funding from the Department of Health to set up and provide the service.
Okay. And is that conscientious objection then, or is that what?
Yeah, I think it's conscientious objection.
Okay. Yeah. And what are your thoughts on that?
I don't have a problem with conscientious objection. I think everybody has the right to that, but what's really important is that if you object, that you must refer that woman on to someone else who can provide the service.
Okay. And are you seeing that is happening, or are women being told or try to be convinced that it's not the right thing to do?
I think the best, first step for a woman who's considering a termination of pregnancy is the My Options helpline or website. And they provide very good counselling, information. There's also some women who don't want to go to their own GP for whatever reason, and they can look and see a list of GP providers in their area or close to their area where they can go and have a termination.
Okay, so they're the best places to look, because I have heard of women going on Googling, I suppose, abortion care in Ireland, and some groups popping up, and they may be called women's advocacy groups, and they go there and they're given pamphlets that actually talk about God and Jesus, and it's not a nice situation for women to be in. So the best place for a woman to get the best option and be told what services can be provided for her in the area is myoptions.ie.
Yes.
Okay, great. Well, we have that clear now. And then the third group of people that you were talking about, which is the women that have if they were to continue with their pregnancy, it could have a detrimental effect on their lives. Does that include psychiatric issues, and is there much of that?
It does include psychiatric issues. One of the difficulties with that is the way that the legislation is written. So what it says is that they must have a psychiatric condition which is negatively impacting them, but that a termination must relieve the effect of that negative impact on their mental health. So basically they're trying to say that if you have depression, suicidal ideation, if you have a termination, that will definitely go away.
Oh.
And it's very hard to know that for sure. Mm-hmm. So the way the process works is that they see an obstetrician and a psychiatrist, usually a perinatal psychiatrist, and that the two of them must sign the form to say that yes, they believe that it's negatively impacting the woman's mental health, and that a termination will likely result in an improvement in their mental health.
Okay. God, there's loads to it, isn't there?
There is.
So, and will it change? Like, there's talk about the legislation changing and making it that bit easier. What do you envisage happening?
I think very little is going to change, unfortunately. And certainly listening to politicians, what seems to be being said at the moment is that they don't want to change a huge amount. But I guess if there was one thing that I could pick, it would be that 3-day rule for the under 12 weeks. If we could get rid of that, I think that would be a good first step.
Yeah. And do you ever look and see what's happening in the States? You know, they had abortion for years and then it's what seemed overnight, it was taken away from a number of states.
Yeah.
Could that easily happen in Ireland? Something like, could overnight this go if, you know, we took our eye off the ball? Do we need to be constantly pushing, demanding, advocating for ourselves as women, but also not allowing things to creep in or a certain cohort of society to... Yeah.
I think one of the reasons that the legislation was changed was because people spoke up and people shared their experiences, and it made people think, well, look, what if that was my sister? What if that was my friend? What if that was me? Mm-hmm. And by putting, you know, a human face to the problem, it made people more open to the change. And I think there were a lot of people who said, well, look, I don't like the idea of that, and I'm not sure, but I don't want to deny someone the option.
Yeah.
And that's how the yes vote was successful. But I do think we need to keep looking at it and keep talking about it.
Yeah, I would agree. I would worry and be really fearful that we take our eye off the ball and it's just whipped away as well.
Yeah, and it'll still happen. It just won't be as safe. Or you'll have people travelling, and that's not right either, because then they lose out on the supports that they get here. So for those women who have babies who have fatal abnormalities, they're linked with a team here. And that's everything from their fetal medicine specialist to their bereavement support to our social work, psychiatry, anything that they need within our maternity services. And we do our best when they come back to continue to look after them. But, you know, ideally you want to provide the service in their home country, their home environment.
Absolutely. And I think what's really important is that it's never a decision that any woman takes lightly. And we need to give women the power and the autonomy over their own bodies.
Yeah,
and I think that sometimes that message can get mislaid when people that don't agree with abortion are speaking out. Do you ever have any pickets outside hospitals, or do you ever hear of anything like this happening?
Yeah, I've definitely heard about it. Probably less so than there was initially. It is a problem though, and you don't want someone to feel that they can't come and avail of a service because they're going to be targeted. With a maternity hospital, people don't know what they're coming into. So they could be coming in because they've got a cyst on their ovary for a gynaecology clinic. Yeah. And there isn't a sign on the door saying you're coming to the termination of pregnancy clinic. Yeah. But I have heard of people coming in to the hospital, shouting at people with pickets, you know, saying terrible things to the women, which isn't right.
No, goodness. Oh, okay.
Yeah.
Okay, we're going to move on and we're going to talk about the induction rate in Ireland and the intervention rate in Ireland. And there would be a cohort of people out there that think that we have too many C-sections, and I want to know the reason why we have the induction rate and the C-section rate that we do, and I want you to shed some light on it as an obstetrician working in, you know, in the front line, and you see it day in, day out, and why it happens.
There's lots of reasons.
I know. So basically now what I'm going to do is I'm going to sit back and not ask any more questions, because I think you could talk for hours on this. But, you know.
We do have too many C-sections.
Yeah, okay. Well, yeah. So let's discuss. So you've said that now. Let's discuss.
I spent a lot of time in my antenatal clinic talking to women about cesarean section.
Okay.
And I think that they should be allowed to choose. Everyone, it's their body. If you choose a cesarean section, that's absolutely fine. But what I do sometimes see is that women who have had maybe a difficult first delivery, so they might have had a forceps delivery or a postpartum hemorrhage afterwards, and there's a lot of fear and anxiety around the next delivery, and they think that a cesarean section would be the best option. But actually, when you drill down into it, we know that a second vaginal delivery is often very quick, very straightforward. Chance of needing an instrumental delivery are extremely low, like they're under 10%. The chance of a postpartum hemorrhage would probably be lower because we put interventions in place like medication to reduce that risk, and that the delivery is usually very quick, straightforward, very few stitches. And then the woman gets out of bed pretty much straight away and can go home on day 2 with her baby and can look after her toddler and isn't recovering from surgery. Mm-hmm. And what I find is that it's sometimes important, as you get closer to the time and the anxiety creeps in, that you can provide that reassurance and that support for those that probably do want to have a vaginal delivery but are frightened. And then for those that do choose a cesarean section, like that's absolutely fine. And it's not the easy option, and they know that it's not the easy option because it's a surgical procedure, and then you get a baby afterwards to mind. And you know,
I know. Do you know what? It really pisses me off when people say, "Oh, she's taking the easy way out, getting her C-section. It's coming out through the sunroof. Look, she's too posh to push." Like it's outrageous that this is that women again patronising and just it's horrible.
Yeah, and what is most important is that every woman and every baby who needs a cesarean section has a cesarean section. So we don't want to negatively impact the women's health, the baby's health. But the more cesarean sections we do, the more we're going to end up doing, because our VBAC rate, or vaginal delivery after cesarean section rate, is really low. And
okay, I never thought about it like that. Yeah. So the more you do, the more you do.
Yeah, and that's why the rate is going up and up.
Okay.
Because the elective repeat rate, and then if you have 2, you're more likely to have another, and then if you have 3, you're going to have another. And so we end up doing more for that reason.
Okay. So interventions and inductions, etc., are they high because of the litigation rate in Ireland and the fact that we are very litigious? We're, you know, taking over America in terms of suing obstetricians, hospitals, the state, because of things that can possibly go wrong with delivery. And is it a case that an obstetrician will just do it because they can't? They don't want that outcome. It's an absolute. It's a heartache for absolutely everyone involved.
I think the induction rate is going up because the women, I guess, there are more reasons that women need to be induced now.
Okay.
That didn't used to be there. So, for example, what we call post dates, where you're past your due date, there's good evidence there now that says we should think about it at 41 weeks rather than 42 or beyond, because of the risk of stillbirth. And for a woman in her 40s, the risk of stillbirth at 40 weeks is actually the same as a woman in her 30s at 41 weeks. So you're pulling it back even further.
Okay, so the risk of stillbirth goes up as someone gets older.
Yeah.
Okay.
And, you know, if you are inducing someone before their due date, like the chances of them going into spontaneous labour are lower, because most people go into labour between 39 and 41 weeks. Mm-hmm. And then when you throw in the other pregnancy problems, so diabetes, preeclampsia, high blood pressure, bigger babies, smaller babies, And we're getting better at picking up things like these. You know, scanning is better. We can pick up the small baby that needs to be delivered, again, to prevent a stillbirth. So that woman then ends up getting induced. And we're now at nearly 50% for first-time mums. I was induced with my first baby.
Were you?
I was. And
we're nearly at 50% induction for first-time mums.
For first-time mums.
Okay.
Yeah. So it's very high.
Is it because women are having babies older as well?
That is a factor.
Okay.
Partly because of that stillbirth risk, partly because we know that diabetes in pregnancy and high blood pressure are more common as women get a bit older.
So the diabetes and the diabetes and the high blood pressure increases as well with age.
Yeah.
And is there an issue with weight as well? Are women becoming pregnant, or are they pregnant and they're more overweight than they were years ago?
Yeah, and so one of the reasons we screen for diabetes in pregnancy, like the main reasons people get screened are they have a first degree family relative. So mum, dad, brother, sister with diabetes, their BMI is 30 or more, and their age is 40 or more.
Okay. Because a question that did come in was saying, is the screening for gestational diabetes a bit OTT?
Well, no, because if you don't pick it up and your blood sugars are running high and all over the place, you can end up with a stillbirth. Okay. You could end up with a really big baby who gets stuck at the time of delivery, gets deprived of oxygen and has cerebral palsy.
Okay.
So that's why we're so keen to screen to prevent those problems. Now, what I would say is most women who have gestational diabetes, who are diet controlled and have a normal sized baby, can be induced at 7 days over, like someone who doesn't have diabetes, and that both they and their baby are absolutely fine.
Mm-hmm. Okay. Is cerebral palsy something that happens at delivery, or can it happen before delivery? Can it happen in utero, and how can you tell, or can you tell?
A lot of it can happen in utero. Okay. Some of it will happen at delivery. We're getting a little bit better at looking at timing, and that's based on MRI scan of the brain and the changes they see. Now the paediatricians know more about this than I will, and the radiologists. But yes, they can sometimes time it and say, look, it was during labour or delivery, or it was antenatal.
Okay. Because then, is that an issue then if a baby is born and they have cerebral palsy and the family want the best possible outcome for their child, and they might decide to sue to get the care that they need because the care isn't there, and that might be what, you know, I've heard that's the reason why families will sue, because they need to sue to get the care that they so deserve. So how do they decide, like, whether it definitely happened during delivery or whether it happened in utero? Is it some cases we just don't know, and
some cases we don't know? And what's very unfair though is for those where there isn't negligence but they still have a baby that has a disability, and who pays for that child's care? So if we didn't pay out so much in legal claims, we could have state funded care for more children with disabilities and better services, like they do in, I think it's the Scandinavian countries. There's a no legal process for birth injuries or antenatal injuries, and that every baby that's born with cerebral palsy or other disabilities is given money and is given a certain amount of care so that the families can look after those children.
That seems like a brilliant idea.
Better plan, I know.
Is there any way? Is there anyone even trying to get that introduced into Ireland? Or
I don't know. It came up actually on a podcast that I was listening to. Declan Keane from Holles Street was talking on the Fifth Court podcast, and that was it was one of the things that came up, and it came up at another legal study day recently where they were talking about it as a great concept, but I don't know if anyone's trying to introduce it.
Yeah, it would be ideal, wouldn't it? Because otherwise, you know, I feel sorry for everyone involved, the doctors, the family, the child. It's just, it's not a nice situation for anyone, sure it isn't.
And when things don't go well, even if you've done your best, you still feel absolutely terrible when someone has a complication. And there are certain things that will stick with you and you take with you through your career.
Yeah, I can imagine.
And like it's difficult for everyone involved.
And how do you cope with that kind of thing? Do you go for counselling yourself? Do you just talk with your peers? Are your peers a great sounding board when things like that happen?
Yeah. And I would say to all the trainees as they're coming through, you need to phone a friend. You know, you've had a busy night on call and you've had a difficult delivery and, you know, you're thinking about it. You need someone to ring to chat through it with, and someone who'll understand, who's been in a similar situation.
Yeah.
And that just because you have one difficult delivery doesn't mean you're a bad doctor. Sometimes complications happen.
Yeah, my goodness. It's just one of those things, isn't it?
Yeah.
What are your thoughts on home birth?
One of the things now that they've introduced is that the home birth scheme is under the HSE and the hospital. So I would sometimes have women coming into me with the form saying, can you sign off to say I'm okay for a home birth?
You're like, no.
And I'm like, well, I actually don't have a problem with home birth. And I think if they're low risk and there is a very detailed form that is filled and they tick the boxes to say they have, you know, no significant medical conditions, no past obstetric condition, that would mean that they'd be high risk to have a delivery at home. But I kind of feel like
mothers allowed to have, not allowed, that's the wrong term, but can a first time mother have a home birth?
Yeah, absolutely. In the Netherlands, like the home birth rate is huge. And I actually worked with a Dutch guy and they had vaginal breech deliveries and home births and,
wow.
You know, I think about 30% of deliveries in the Netherlands are home births.
But there's obviously the care that's built around that too, is there?
There is. And Holles Street run a home birth scheme, which is absolutely fantastic. You have 2 extremely senior labour ward midwives that go out to each delivery. And there's a midwife who was working in the Rotunda who was doing home births and was also working on the labour ward. Sarah McCann is her name. She's absolutely fantastic, and she's now left to go and do home births the full time. And I'm totally devastated because I loved when she looked after my patients who wanted a very natural labour and delivery, and she's so supportive. She does hypnobirthing classes. So while I don't have a problem, or I would support home birth for a low risk woman, I kind of feel that I'm not involved in it. I'm not going to be the person that's there. Mm-hmm. They have their midwife who's looking after them. And I feel like it's separate from the hospital system.
Yeah. You're talking about the midwives in Holles Street. I had all 3 in Holles Street with the community midwife scheme, and I actually wanted to become a midwife after having my first, because I just had such an amazing experience. I was really lucky. All my deliveries were fantastic, but some women just don't have that. Can I ask you about birth plans?
Yeah.
And you're laughing.
I'm laughing.
Because I think that nowadays a lot of us want to be in control of birth, and we want to have our birth a certain way, and that's really understandable. Someone wants it to be, we want it to be a beautiful, magical experience, and we're told it's the most natural thing in the world, and this is the way we want to do it. And we'd have a lot of, I suppose, women that just, they want to do it this way and this is their plan. What are your thoughts on that? And or do women end up being really disappointed? Yeah,
that's one of the things I worry about.
Okay.
So I like a plan A and a plan B.
Okay, I love it.
Or birth preferences rather than a plan.
Okay.
And like, I know even for myself, I remember before I had Paddy, my eldest, I was like, I'm definitely not having pethidine. I don't like the idea of it. Like, sure. Once I was in labour, I was like, give me all the drugs.
I know. It's like, you take anything.
Changed my mind very quickly.
Yeah.
And some of the things that would come up that I would see in birth plans would be, I don't want an epidural. Which is grand. But like, you can change your mind on the day. So if you do decide on the day that you want it, that's fine. Like 80% of first time mums have an epidural. Much lower second time round because it's quicker.
Yeah.
The other things that people would often say is, I only want an episiotomy if it's medically indicated.
Okay. And what does that mean?
Well, why would you do an episiotomy if it's not medically indicated? So I think they're expressing that they don't really want an episiotomy. Like, who does?
But it's better than tearing though, isn't it?
It's better than a 3rd degree tear, which is where the tear extends down into the anal muscle and can leave you with incontinence.
Okay.
So the reasons we do an episiotomy would be baby's distressed to speed up the delivery, the delivery's not imminent and you've been pushing for more than an hour and the perineum's just too tight, or it's starting to tear and you think it's going to be a 3rd degree tear. But we always ask for consent. So no one has, or no one should
Sorry,
have
what
an
do you mean
episiotomy.
it's starting to tear and you think it's going to be, can you stop it? What, like if the head's crowning, like it's going to fucking come out, no?
So the episiotomy is cut to the side.
Okay.
So you're angling away from the anal muscle.
Okay.
So rather than tearing straight down, it'll tear to the side.
So you can see the tear, so it doesn't just like rip quickly. You can see the tear starting and
but you can sometimes see it starting.
Goodness, you have a real eye for it, don't you?
Yeah. Well.
That's where your training comes in.
Exactly.
So yeah, there is that thing about episiotomies, isn't there?
So that comes up. Instrumental delivery comes up a lot. And again, I'll often say to women, like, I had a vacuum delivery for my first baby. It was absolutely grand.
Was he born with a little cone-shaped head?
No, we had a little circle from the Kiwi cup. I didn't have an epidural. And what I'd say is it feels no different than having a spontaneous vaginal delivery. The cup is on the baby's head.
Yeah.
The forceps, the diameter is a little bit wider. And I can understand why someone doesn't want a forceps. Because there are more risks for the mum, there are less risks for the baby.
Yeah.
But that's something that you should discuss antenatally and go through, I guess, your fears, your expectations, and decide, on the day, what is the right thing. I had a patient not that long ago who had said, I don't want an epidural. And she had an epidural and that was fine. And she said, I don't want an instrumental delivery. And when it came down to it, she was pushing really well and she would have had a vaginal delivery. It was going to take another 20 minutes probably. And the baby was showing signs of distress. And, in that moment, she's like, look, whatever's best for my baby, that's totally fine. Mm-hmm. And because we discussed it beforehand, she said, look, well, we talked through these before, and while it wasn't my preference, I was okay with it, and I was happy that we'd had the chat before, and I was happy that you were there, and we'd had that continuity, and that she was well and baby was well afterwards.
Okay. Yeah.
But look, if someone says, I'm not having that, like, no one's going to force them. It's your body, it's your choice.
But ultimately, at the end of the day, the mum is there and everyone wants the outcome for a mum to be happy and baby to come out happy and safe. So, but is there ever a time where you need to intervene and do something that the mother's like, I absolutely do not want this to happen? Does that ever happen? You do see women who, with cesarean section, who really just don't want a cesarean section under any circumstances. Yeah.
And it can lead to quite a bit of disappointment then if they don't have a vaginal delivery.
Yeah.
And sometimes people need extra time. So they might say, look, I don't want my waters broken. That's fine, but the labour hasn't progressed. So we might think, well, look, that's the next step. We'll do that. And then the labour still hasn't progressed. And then we think, well, maybe we'll start a bit of oxytocin to get the contractions working a bit more efficiently. And we do that and maybe that doesn't work. And then, I had a patient, now this was a long time ago, who was 8 centimetres. This was when I was a registrar. And I said, look, you've now been 8 centimetres for 4 hours. And
oh my goodness, for 4 hours?
Yeah. And it does have an impact on the pelvic floor long term. And I said, look, I don't think that you're going to have a vaginal delivery. The baby's head is not in a great position. It's looking up at the sky, so back to back. And she said, I'm not having a section. I said, hey, well, look, that's fine. Take some more time. And then another hour later, and there's still no change. And at this stage, I'd rung my consultant because that's what you have to do as a reg. And they said, look, ideally she should have a cesarean section. And even at that stage, she was like, well, I'm just going to leave. I was like, no. You can't leave. You have an epidural. Look, we're not going to force you into anything you don't want to do. So we took another hour.
Okay.
And at that stage, she was still 8. And she said at that stage, look, I don't want a section, but I'm grateful that you've given me the extra time. And now it's okay. I'm okay to go ahead and have a cesarean section. And when we go to theatre, we always do another examination to make sure that things haven't changed, and they hadn't. And she did have a cesarean section. And just because you have one, though, doesn't mean you have to have another. So back to the VBAC. Like, I'm a huge advocate for VBAC, and I've had lots of women.
Okay, so it's not one of these, because I you hear that VBACs aren't necessarily amazing, and they can be difficult as well. And the issue with VBAC is that you worry that the uterus will rupture. Is that it? Because of the stitches?
Yeah. So,
or the scar tissue.
The scar tissue. Yeah. So the risk of rupture is somewhere between 0.3 and 0.7%.
Okay, that's low.
It's low, but you know, we might have 1-2 a year in a big maternity hospital delivering 9,000 babies. It goes up a bit if you have oxytocin, or if you're induced, it can go up to 1%.
Okay.
But I guess if you have a VBAC and then you go on to have more babies, you can have more VBACs.
Okay.
And if you're going to have a big family, it's definitely something to think about. So if you want to have 4 kids, the more sections you have, the more complications you can run into. Whereas the more vaginal deliveries you have, the lower the complications each time.
And if the uterus ruptures, is that, well, obviously it's an emergency, but can that have an awful outcome, or can you generally get the baby out on time safely and the mother safe and well, or is it a total awful show?
It depends.
Okay.
So when we see signs of it, we do act very quickly. Sometimes it's quick enough that the baby's fine, and sometimes the baby is oxygen deprived and has cerebral palsy.
Oh God, that's awful, isn't it?
It is. And for the mum, depending on how the rupture happens, there is a chance of hysterectomy if the womb can't be put back together.
Jesus.
Yeah.
Like, there's so much that can go wrong with childbirth. We're really not designed for it well, are we? We used to walk on all fours, and they say that we compromised our hip size and our pelvis to walk on 2 legs, so we were able to use our hands more.
Yeah.
And as a result, that compromised the way we give birth. Because in the wild, sure, you have elephants and you have cows and they're able to just shoot them out. But we need so much care. Like, it really is a product fault, isn't it?
Yeah,
like all the things that can go wrong.
I mean, if you look at what happens in the third world, where there's very little antenatal care in lots of places, the complications that they see are much higher than what we see. So I guess we're balancing the fact that we're intervening more against the fact that we have better outcomes, like our perinatal mortality rate, our maternal mortality rate are extremely low. But you are balancing that against more intervention.
Jerry Agnew was on the podcast, and he said that there was a study done in the UK where there was obstetrician registrars, and if they were surveyed and if they had a choice, they would opt for a C-section rather than a vaginal delivery. What are your thoughts on that?
Yeah, I read that paper as well. I try to think about my peers, and most of my peers actually have had vaginal deliveries and chose that. Don't know about the younger groups coming through. Like, I particularly wanted to have a vaginal delivery. I didn't want to have a section when I was pregnant, and that's part of the reason I picked my obstetrician.
Yeah.
So
you told me you'd seen him do amazing. No, you said the word. This, I love this. No, I love this. No, I love the way you described it. You said I'd seen him do a beautiful instrumental deliveries. Yeah. So that's why I wanted him. I just think even just to describe a forceps delivery as beautiful means interested in him.
Well, a forceps should be like, you shouldn't be pulling very hard. You're guiding the baby out. So it's a simple movement.
You have to have strong arms, don't you, as obstetricians?
I don't know where my arms that strong. Maybe from carrying the kids.
Pulling these babies out.
I definitely probably should work out a little bit more, go to the gym a bit more.
Not at all, you're fab. But no, it is interesting that doctors would opt for it. But I suppose they see more problems that happen. Therefore, you know, it would make sense. I remember when I told my brother I wanted to have a natural birth and no epidural, he thought I was mad because he's a doctor. He said it's like going for a tooth extraction and not having a local anaesthetic. Yeah. I was like, is it similar? Maybe. But anyway.
I don't know. I think the longer I'm doing this, the more I'm open to everything. Like someone wants elective section, no problem. Yeah. Someone wants it all natural. Like, we do our very best to help them through that. You know, we've got a birthing pool in the Rotunda now.
Do you?
Yeah.
What size is it?
Oh, it's bigger than a bath. Like, it's pretty big. Now, it's for labour. It's not for delivery.
Okay.
But it's great pain relief.
Oh, sure. It's wonderful. Sure. I remember just being in the shower with the shower beating down on my back. I had back delivery, back.
Oh yeah.
Contractions. Oh, awful on my first. But that's wonderful. And is that water just do they need to fill up with a hose, or is it the water is tap on? Okay, and they can empty it and keep it going. But they can't. They have to get out of it for delivery.
For delivery, yeah.
Okay, and is that because of complications that could arise if the baby is born underwater?
I don't know. I think that's just the way they've set it up, and I guess training as well. So, our midwives had to be trained to look after women in labour. So, like we do intermittent auscultation with the handheld Doppler. And they're waterproof, which I didn't know until we got the bath. You can use the Entonox gas in the bath as well. So it's not that you can't have additional pain relief. You can't have an epidural in the bath.
Yeah, well, that makes sense.
And you can't, we don't have mobile epidurals. That's something that people often ask a bit about as well. And we do have mobile CTG machines, the belts we put on to monitor the baby.
Yeah.
We have mobile wireless ones. People can walk around, like if you're being induced and you need to be continuously monitored, you don't want to be stuck in the bed.
No, or lying on your back, which is horrible. It's just the most it's the most unnatural thing, lying on your back, isn't it, when you can feel your contractions. So what is a mobile epidural? So
basically you have the two belts on and there's a thing connecting to it that wirelessly transmits to the CTG machine so that we can read the baby's heart rate and your contractions on that and you can walk around.
But a mobile epidural is
a mobile epidural.
People can. It's the epidural is very specific, isn't it?
Yeah, and I think it's a lower dose block,
and people can walk and move around with it, but they just don't feel the contractions in their belly. It must be a strange feeling.
I know.
Like half of you's numb, or like the middle part of you's numb, but the rest of you has feeling.
Yeah.
Okay.
I didn't have an epidural with any of mine, so I don't know.
Not by choice. I did have the nitrous oxide though. I loved it.
I loved that.
I was wrapping and everything. I loved it, and I remember asking the midwife, "Can I take some of this home with me?" I was
no.
I love it. I loved it. It was great.
I was laughing, and my husband was like, "What's so funny?" And I was like, "Oh, I don't know, but it just is."
Being as high as a kite, isn't
it? Yeah. So there's lots of good options, and the TENS machine as well. That's great.
I got no relief from the TENS machine. Sorry. No.
And there's a new thing called a winner flow. Have you heard of this?
No. What is this?
So it's a little mouthpiece that looks like the Entonox gas, but it's just like a little whistle. And there's a whole video around the technique to use it, but it's to do with breathing and your abdominal muscles and helping the baby descend and the cervix dilate, as well as kind of keeping you calm, kind of as part of a hypnobirthing process. Okay. And I've seen one or two women use them and they seem great.
That's lovely. Anything to improve the processes is great.
Yeah.
What's the infrastructure like in the hospitals in Ireland? Are they a little bit old?
Yeah.
Is it hard to move around? And like you see some of the private healthcare settings and they're fabulous and big wings and things like that, and then sometimes you go into the maternity hospitals and they're as old as the hills and you've women walking up and down stairs that are really narrow. Is there anything being done about that? Like, what's that like to work in that environment? And then if you're very busy for women,
the labour wards certainly have improved hugely in all the hospitals, and a lot of money has gone into revamping those, but the postnatal wards is really where the money needs to be spent.
Okay.
And as part of the new recommendations, like when Holles Street moves to Vincent's, if it ever moves, it'll be single occupancy. And the Rotunda is going to be doing a refurb as well, which I'm not sure when it's starting or how long it's going to take. But again, the aim is to have single rooms for women. So postnatally, you're not in a room with 10 other women and 10 other babies.
Okay.
You have your own room, your own toilet, some privacy.
Yeah.
That'll
be ideal.
Yeah. Yeah.
Well, that actually brings me into the next question about the consultant's contract and the talk that there is with the new consultant's contract that there wouldn't be any private maternity care in Ireland. Now, I think that about 30% of women opt for private maternity care. So I know that they can't force any consultants to sign that contract that are currently working. So they have to phase you guys out.
Yeah, phases out.
You have to get as old as the hills and phase you out. But is that the way it's going to go in Ireland, where there will be no private option for women? And what are your thoughts on that?
They're trying to turn us into the NHS, I think.
Yeah.
The difficulty is that there's no private hospital. So it's not like if you take it out of the public system, it can go somewhere else.
Yeah.
It can't, and it never will, because the indemnity is just too costly.
Okay.
So we're not going to have another Mount Carmel. So you're taking away women's choice. And I've had my own patients ask me, well, when I come back in 2 years' time, I was like, I'll still be here and I'll still be on my contract and it'll be fine.
Okay. Sorry, can you just explain to people what the contract, what we mean by the contract?
So currently obstetricians are on a type A, B or C contract. A is public only, B is public and private on your public hospital site, and C is public and private, but you can do private off-site.
Okay.
And that's really for gynecology, not for obstetrics. Most people are on that type B contract. The new Sláinte Care contract is part of the Sláinte Care model, where it's only public care in a public hospital. So what that means is for doctors coming through, that they will provide their core working 37 hours in a public hospital, and they can provide private care outside of those hours in another hospital. But again, for obstetrics, that doesn't exist.
That's not possible because there's no private hospital.
It's not possible. Okay. They often talk about money. The new contract is a bigger salary.
Yeah.
So some people may choose it for that reason, and other specialties where you can divide your time publicly and privately. Like public care is great, and you know, I would look after high risk women with medical conditions like renal transplants who are in the public system, who will see a kidney specialist, they'll see me, and they get very good care. So it's not that public care isn't good, it's that some people want the continuity of private care. And in the public clinic, so in my public clinic, there could be 60 women, and they won't all see me at every visit. And
I see you no visits.
I usually I try and see them at least once.
Oh, there she is. She's gone.
I know. I always say to them, I was like, I'm in room 3. I'm always in room 3. My name is on the door. If you specifically want to see me, tell Susan, who's our care assistant. But some women want to see the same doctor at every visit. That's part of the reason the community midwifery service is so good, that you can see ideally the same midwife or a small team. But yeah, for the private care, some people want to see the same doctor. They want a consultant there for their delivery. And they'll see that consultant right from 9 weeks up until 6 weeks postpartum for all their visits. And I love that. I love seeing people right the way through. And I've had a couple of women now where I've delivered their 3rd baby.
Oh my goodness.
So yeah, like it's great. I mean, I love my job.
It is a great job.
It is.
You're seeing babies being born all the time. What's your favourite part of your job, actually?
The delivering babies, of course.
Because my mum's a midwife, and she would have worked with you, or she says that she would have known you from the Coombe. And she always used to say she just loved delivering babies. Loved it. Like there was nothing like it. I think that's why I'm obsessed with babies. We're all obsessed with babies in our house. And there's just something so gorgeous about them, isn't there?
And I love when they bring them to the 6-week check, and I'm like, oh, let me have a little look. Not that I want any more. Like I'm done. My youngest is 7. The ship has sailed away into the distance. But yeah, no, I love the babies.
They're gorgeous, aren't they? I just love them. You know the way. There's nothing like that feeling when they're put in your chest and they're mewling like little kittens.
Yeah.
That rush of whatever it is, it's oxytocin. It must be what it feels like to take heroin or drugs or something, because it's just the feeling is just unreal, isn't it?
And a patient of mine who sent me a photo recently, she was one of those, I delivered her 3rd baby by cesarean section, and she got this, her husband got this action shot of, we drop the drape after the baby's out before we cut the cord. So there's a photo of me holding baby Louie up in the air for her to see, and her husband captured it.
Oh, that's
it's
fab.
Cool. Yeah.
Oh, actually, what do you think about are people allowed to bring phones into the delivery and deliver everything? Are they deliver everything, video everything? Or is there is there any privacy criteria that they need to meet, even in terms of like videoing you or getting in your face? Like, what would? So
officially, I guess no. Like they can bring in whatever they want, and sure, we had a camera crew in the Rotunda, but I guess it is. Prefer to be asked, and there are certain points where it's not appropriate to film. Photos, no problem. But the filming, case by case, I think. But it is nice for them to have a memory of that. I don't know whether I wouldn't want to film my deliveries. They're like not my finest moment.
What, in hindsight, like maybe for myself to look at, and only myself, but I do wish the smartphones were around. They really only came on trend a few years ago. So I have very few pictures of me with the babies when they're young, because it's always, I've loads of pictures of the babies and loads of pictures of my husband with the babies.
Yeah.
But there's none of me.
Yeah,
I did all the work.
But I find, because I have, so Patrick, Holly and Jack, and Jack has hemangiomas, so he has a little strawberry birthmark here.
Yeah.
And I'd be looking at a baby photo, I'm like, which one of the boys is that? And then I look close, I'm like, that's Jack, because he's got this little strawberry mark.
It's so funny, isn't it?
Yeah.
And how did you obviously you have 3 children, and how did you do it? How did you, because your eldest is what 13?
13,
so you were in the thick of studying and training when he was born, and when you were raising the 3 of them, I suppose, when they were small babies.
Yeah.
So how many nannies did you have?
So I did have a live-in childminder for 8 years.
But of course you did. How can you cope otherwise?
Yeah.
But how did you find it? Did you find you were, it's like whack-a-mole, where you feel, okay, you're firefighting here, firefighting there. You're never in the one place fully, because it must be tough, is it?
Yeah. Like, my husband's great.
Is he a medic?
No.
Okay.
So that's really
always
important.
A good thing, isn't it?
Don't marry a medic.
Yeah.
He calls himself a civilian.
Yeah.
It's much easier because he travels a little bit for work, but he doesn't work nights and weekends.
Okay.
So with my job being like, sometimes I'll leave in the middle of the night and he'll be like, were you gone at some stage last night?
Really? And
Yeah.
you're back in bed the next day, like as if
Yeah.
nothing happened. Oh yeah,
Yeah.
I just delivered a few babies and back.
Yeah. Or he'd sometimes hear the phone go off and he'd hear the kind of spiel in the background. So yeah, like, I guess we just made it work, and it gets easier as the kids get older.
Yeah.
When they're young, it's hard because you're just tired. I think anyone with small children is tired all the time. And then when you're working nights, you're tired all the time and drink a lot of coffee. And then it gets a bit easier when they get a little bit older. But then you also want to be there for certain things. So like, I'd find I used to do a night on call so that I could be off the following day to go to their sports day or to bring them to the dentist, or you just make it work.
Yeah.
Quick.
You're like a zombie going for this, but at least you kind of make it work. Yeah. Okay.
Yeah.
Is the outcome for pregnancy for women that are working in obstetrics themselves, is it as normal as the lay people, or is it a little bit more risky?
No, it's definitely more risky. So if you look at all the people I know, and certainly years ago when people used to work nights and do 24-hour shifts up until the end of pregnancy, the outcomes were not good.
Oh my goodness. I can imagine just being on your feet and that is just not right, sure it's not.
So when I was training, it came in that you didn't have to do call from 24 weeks. And the outcomes have improved a bit, but we still do see complications, and I think we try and mind each other as well quite a lot. There's a lot of women in obstetrics, and I'm sure the men that are in obstetrics are great as well. We can't forget about them.
No, they are. Because they're in obstetrics for a reason too. They've some affinity to that.
Yeah. And yeah, it's just about minding each other, because as I was saying to you earlier, you know, you'd be picking up a few extra calls for somebody who's pregnant, but then when you're pregnant, they'll be doing it for you. So it all evens out.
So there's a kind of a force of friendship there, is there? That
yeah.
That's lovely.
Yeah.
Is there anything else that you'd like to say to women out there who, just in general, about obstetrics, about gynecology, about anything to do with their bodily autonomy?
I think there's a lot more awareness around, you know, fertility, getting pregnant, and that can generate some stress and anxiety. And for women not to be too hard on themselves. And again, during pregnancy, and as we spoke about the birth preferences and the birth plans, that like, pregnancy is hard. It really is. And women do the rest. And I guess what we want is a healthy mum and a healthy baby at the end. And that includes mental health as well. So it's not just physically, that we mind our mums, and again, postnatally, really important, because it can be lonely when you're, you know, sleep deprived, you have a new baby, you're tired, and all that hormonal change, that we mind women as they get into that 4th trimester as well.
Do you think there is enough care there for women in the 4th trimester though?
No. No. And it's something that we're putting more of a spotlight on. It's a great intervention actually in the Rotunda. It was on their Instagram recently. It was a postnatal cafe, and it was for new mums to meet together so organised by the Rotunda, that they could just go and have a chat and meet other new mums, and I guess building a support network there. So, you know, we've great perinatal mental health support services, but they are stretched.
Yeah.
Same with breastfeeding support. Like,
Oh yeah.
you know,
Don't get me started on that. That's
we could do with more
podcast.
of that. Yeah.
Yeah, I know. And but with the perinatal mental health issues as well,
Yeah.
and postpartum depression, there's a lot of women that might feel that they didn't get the support that they should have got in those early days. You know, if you had a magic wand and you could do something, what would that be for that group of people? You know, that, you know, because I think what happens is we do a very good maternity care. Women are looked after a lot in pregnancy, and we're seen by people, and we're cosseted. You know, we are minded, and we're always asked, how are you and how's the baby and the bum? And then we give birth and it's all about the baby. Yeah. And the woman is sometimes forgotten. And it's not that the woman's like, oh, hey, here, I'm here too. But that woman is going to be raising that child, and that woman is responsible for that child and probably others. What should we be doing?
I think that's where the GPs come in and really shine. So I've often seen that someone will go for a 2-week check for their baby, and the GP will spot that something might not be quite right, or they'll ask those questions. Yeah. And the quicker you kind of open the door and talk about it, the quicker you can get that woman back to a place where she's well. I'd love to see a 2-week check for all mums, and I'd love to see more community midwifery or public health nurse support, like building their numbers, because like they're doing a great job, but there aren't enough of them. And part of that Sloan care system is more community care. So building on that in the community, certainly in the first 6 weeks, and maybe even beyond that as well.
Yeah. That'd be great, wouldn't it?
Yeah.
We'll start it in force. Vicky, I ask my guests 2 questions at the end of every podcast.
Oh yeah, I know.
What advice would you give young people today?
Yeah, I was thinking about this, and I was thinking about when I was young, which is a while ago now.
Oh, it's not. Would you stop? You only look about 20.
The best thing I did when I was young was travel. So backpacking around Asia, Australia, South America. If you get the opportunity to do that, absolutely go and do it. But the other thing that I would say is that being 40 is as fun as being 20, except that you don't care what people think about you.
It's so true, isn't it?
You're just like more confident in yourself, and so don't be worried about the aging too much, that it's still fun 20 years later.
Absolutely. Yeah, I was a total messer in my 20s, but I'm even more of a messer now because I give much less of a shit.
Yeah, absolutely.
And what is the meaning of life?
So this is a very difficult question, and I think it depends on what life stage you're at. So I was looking up, I was getting all deep. My mum did a psychology degree, and there's a thing called Maslow's hierarchy of needs. Have you heard of this?
Yes.
And the different levels, so from, you know, survival to self-esteem to, you know, finding love, or the last one is self-actualization. I think that's where you've really made it and things are perfect. I think we're all somewhere along that thing. I think, you know, being happy, if that's what you can achieve, no matter what that is, that's what's most important.
That's lovely. And on that, we will end it. And thank you so much, Dr. Vicky. It has been an absolute pleasure to have you here. Thank you.
Thanks, Laura.